Welcome to the Deep Dive, where we unpack your sources and turn them into focused knowledge. Today we're diving into neurofibromatosis, or NF, pulling directly from the revision notes you shared with us. Our goal here is to really go through this complex topic, section by section, highlight the crucial high-yield points, and make it all crystal clear for your revision. We'll be focusing on the main types that popped up in the notes, NF1, NF2, and a mention of Schwannomatosis as well.
Yeah, neurofibromatosis is, well, it's a group of genetic conditions. They affect the nervous system, and they're characterized by tumor growth. For anyone preparing for exams like the MSRA, understanding the differences between the types, the genetics, and just how broadly NF can impact someone, it's really valuable. It presents in so many different ways.
Okay, definitely sounds important. Let's jump right into this material then and make it work for your revision. So based on these notes, what's the core definition? What is neurofibromatosis?
Okay, so at its heart, NF is about genetic mutations. These mutations lead to the growth of tumors, typically along nerves, mostly in the nervous system, but also other parts of the body. And the most characteristic tumor type, that's the neurofibroma.
Right, and the notes really zero in on the main types. There's NF1, also called von Recklinghausen's disease or syndrome, the notes say.
That's right, von Recklinghausen's, and then there's NF2.
What's the key difference the notes highlight between those two?
Well, the material points out that NF1 tends to affect the skin and the peripheral nerves primarily. Think skin signs, lumps on nerves outside the brain, and spinal cord. NF2, on the other hand, its main impact is on the auditory nerves. It specifically causes tumors there.
Ah, okay. And the notes also mentioned a third type, Schwannomatosis.
Yes, briefly. It's distinct because it involves multiple schwannomas, a different type of nerve sheath tumor, but not typically on the auditory nerves like an NF2. Significant pain is often the main issue there, and importantly, you don't see those bilateral vestibular schwannomas that define NF2. What's immediately striking, for revision, is how these related conditions target quite different parts of the nervous system.
That distinction seems absolutely key. Okay, let's move to the root cause of genetics. Where do these mutations happen, according to the notes?
Right, this is fundamental. For NF1, it's a mutation in the NF1 gene that's located on chromosome 17. Specifically, the notes give the location 17q11.2.
Okay, chromosome 17 for NF1.
And NF2.
NF2 is caused by a mutation in the NF2 gene, and that's on chromosome 22.
Got it. And the notes mention the NF1 gene has a specific job, something about suppressing tumors.
Exactly. The protein made by the NF1 gene is called neurofibromin, and the notes describe it as a tumor suppressor protein. So, when that gene is mutated, that normal brake on cell growth is basically lost.
Makes sense. And the inheritance pattern. The material clarifies that both NF1 and NF2 follow an autosomal dominant pattern.
Autosomal dominant, meaning if one parent has it, there's a 50% chance their child gets the mutated gene. Right?
Precisely, a 50% chance with each pregnancy.
Yeah.
But, and this is crucial, the notes also really emphasize that it doesn't always come from a parent.
Right, the sporadic cases.
Exactly. A really significant chunk of cases, the notes say about 50% for both NF1 and NF2 are sporadic, which means they result from a new spontaneous mutation in that individual. No family history.
So you can be the first person in your family to have it.
You absolutely can. And this is a vital point you have to consider NF, even if there's no family history. If we connect this to the bigger picture, these gene mutations disrupt the normal cell signaling pathways that control growth. That leads to uncontrolled cell division and, well, the tumors we see. That breakdown in regulation is the core pathophysiology.
Okay, so digging into risk factors then. It sounds like family history is obviously a big one.
Based on that autosomal dominant pattern, yes. Having a first-degree relative, a parent, sibling, child with NF1 or NF2 is the major risk factor. Gives you that 50% chance.
But just to hammer home the point from the notes, you don't need a family history.
No, you don't. The notes are very clear. About half the cases are due to those spontaneous mutations. It underscores why you always consider NF even without a known family link. And why, as the notes mention later, examining parents for subtle signs is actually quite important.
Let's dig a bit deeper into the how, then, the pathophysiology. How does that mutation actually cause the problems?
Well, it really boils down to the dysregulation of cell growth and proliferation. As we said, the proteins affected by the NF1 and NF2 mutations are normally involved in controlling cell signaling. They tell cells when to grow, when to divide, and crucially, when to stop.
So without that stop signal,
the cells just keep dividing, kind of uncontrollably. And this results in the characteristic tumor formation. Primarily impacting the nervous system, sure, but it can affect many other tissues too, depending on where the cells that form neurofibromas, like Schwann cells and fibroblasts, are found. That loss of the tumor suppressor function, especially neurofibromin and NF1, is really the key driver.
Got it. So how common are these conditions? Let's look at the numbers your revision notes provide. Epidemiology.
Right. NF1 is significantly more common. The notes say it affects about 1 in 3,000 to 4,000 individuals, or maybe 1 in 3,000 births. It actually makes up the vast majority of cases, around 96% of all NF.
Wow, 96%. Much more common than NF2 then.
Oh, definitely. NF2 is much rarer. The figures are roughly 1 in 25,000 to 40,000 individuals, or maybe 1 in 33,000 births. It accounts for only about 3% of NF cases.
And do the notes mention if ethnicity or gender plays a role here?
The material states pretty clearly that both NF1 and NF2 affect people of any race or ethnicity. NF1 affects all genders and races equally. For NF2, no specific gender bias is mentioned.
And we've mentioned the spontaneous mutations a few times.
Yes, and the notes really reinforce that statistic. Around 50% of cases for both NF1 and NF2 are due to those spontaneous de novo mutations. Can't stress that enough.
Another really important point the notes make for NF1, something about penetrance and expressivity.
Ah, yes, very important. NF1 has 100% penetrance with variable expressivity.
Okay, break that down. 100% penetrance means.
It means if you inherit the NF1 mutation, you will develop symptoms.
Yeah.
Guaranteed. That's the 100% penetrance part.
But the variable expressivity.
That means the type and severity of those symptoms can vary enormously. Even within the same family, one person might have mild skin signs, another could have severe complications. It's incredibly variable.
It sounds challenging clinically.
It really is. NF2 also has varied presentations, and the notes mention some specific mutations are linked to more severe disease. Schwannomatosis prevalence is a bit harder to pin down, but it's thought to be maybe similar to NF2. So for revision, remember, 50% spontaneous rate, no family history doesn't rule it out. And that variable expressivity in NF1 is absolutely key to understanding why the clinical picture is so broad.
This leads us perfectly into the clinical features, what NF actually looks like. The notes give a really detailed list of signs and symptoms, and crucially, the diagnostic criteria. What are the hallmark signs for NF1?
Okay, NF1. The most common visible signs, often there from childhood, are the skin changes. You're looking for 6 or more café-au-lait spots, those light brown flat patches. And freckling, specifically in the armpits, axillary freckling, in the groin area, inguinal freckling.
Like clusters of freckles in unusual places.
Exactly. Then you have the neurofibromas themselves. These can be small bumps on the skin or deeper under the skin, and a specific type called plexiform neurofibromas, which can be larger and more complex.
What else for NF1?
Optic pathway gliomas are mentioned tumors on the nerve connecting the eye to the brain. Skeletal abnormalities are common too, and learning disabilities are frequently associated with NF1.
Any other key NF1 features in the notes?
Yes, definitely need to mention iris hamartomas. They're called Lisch nodules. You see them on an eye exam with a slit lamp. The notes say over 90% of adults with NF1 have them, so they're very characteristic. Scoliosis, curvature of the spine is also common, and pheochromocytomas, those adrenal gland tumors.
Okay, and NF2. The note said it's primarily about hearing and balance.
That's really the defining feature for NF2, the development of bilateral vestibular schwannomas.
Bilateral meaning?
On both sides. Tumors on both auditory nerves. This is what leads to the classic symptoms: hearing loss, tinnitus, that ringing in the ears, and balance problems. Other neurological findings are mentioned too, like other types of brain and spinal tumors, meningiomas, for instance, and also juvenile cataracts in the eyes.
And schwannomatosis again.
The key there is multiple schwannomas, but not the bilateral vestibular ones. And chronic pain is often the main, sometimes debilitating symptom.
Okay, now here's where the notes get really specific, and this feels super high yield for revision. The diagnostic criteria. How do all these signs actually come together for a diagnosis?
Right, this is crucial. For NF1, the notes state you need to meet at least 2 of 7 specific criteria. Let's list them out. This is definitely one to remember. 1, 6 or more café-au-lait spots, and there are size criteria. Over 5 millimeters in diameter in kids under 10, and over 15 millimeters in adults.
Okay, 6 spots with size rules. What's 2?
2, that axillary or inguinal freckling we talked about.
3.
3, 2 or more typical neurofibromas or R1 plexiform neurofibroma.
4.
4, an optic nerve glioma.
5.
2 or more Lisch nodules, seen on that slit lamp eye exam.
6.
6, a specific bony lesion, either sphenoid dysplasia, that's a skull bone issue, or a typical long bone abnormality like thinning of the cortex or pseudoarthrosis.
And the last one, 7.
7, Having a first-degree relative, parent, sibling, or child who meets these criteria for NF1. So any two of those 7.
It's a very concrete checklist.
Yeah.
Very useful. What about the NF2 criteria? Are they as complex?
A bit different. For NF2, you need at least one of these scenarios. The main one is finding bilateral 8th cranial nerve masses, those vestibular schwannomas, on an MRI scan. That's pretty much diagnostic on its own.
Okay, bilateral tumors on MRI. What if you don't have that?
Then the other criteria involve family history. So having a first-degree relative with diagnosed NF2, plus you having a unilateral 8th nerve mass on MRI.
So family history plus a tumor on one side.
Right. Or the third way, having a first-degree relative with NF2, plus you having at least 2 other characteristic NF2 features. That could be a meningioma, a glioma, a schwannoma somewhere else, or those juvenile cataracts.
I see. So family history plays a bigger role in the alternative criteria for NF2. Are there criteria for schwannomatosis too?
Yes, the notes give clinical criteria for that as well. You need at least 2 non-dermal schwannomas, meaning not just simple skin ones confirmed by biopsy, and crucially, without evidence of bilateral vestibular schwannomas on a good quality MRI, can't have those.
What if you don't have a biopsy?
There's a possible category mentioned. This is for patients, especially if they're over 30, who have 2 or more suspicious non-dermal tumors, but maybe no biopsy confirmation yet. And again, definitely no bilateral vestibular schwannomas.
Okay. The notes also seem to elaborate on some specific manifestations, like the different types of neurofibromas you mentioned earlier.
Right. They distinguish between cutaneous neurofibromas, the common ones right on the skin surface, often popping up in late teens or early 20s, and subcutaneous ones, which are deeper under the skin. But the ones to really note are the plexiform neurofibromas. The notes highlight their potential for malignant transformation.
Malignant transformation.
Yeah.
Into cancer.
Yes, into something called a malignant peripheral nerve sheath tumor, or MPNST. That's a serious complication mentioned later, associated with NF1 and having a poor prognosis.
That's definitely important to remember. And ocular issues, eye problems.
Yeah, those optic nerve gliomas are key in NF1. They occur in about 15% of kids with NF1 and can definitely impact vision. And the Lisch nodules, those spots on the iris, are almost diagnostic of NF1 in adults, easily seen on a slit lamp exam. In NF2, the notes mention juvenile cataracts or posterior subcapsular cataracts can occur.
Skeletal problems seem quite prominent in the NF1 description.
They really are. The notes list sphenoid dysplasia, that defect in the skull bone behind the eye. Congenital pseudoarthrosis, basically a non-healing fracture, often in the tibia or forearm. Scoliosis is common and can be progressive and severe, and just general issues with bone maintenance. Bowing of long bones, like the tibia and forearm, is also noted.
What about neurological effects beyond the tumors themselves?
Well, the tumors can cause problems just by pressing on things, obviously. But the notes also mention potential malformations in the nervous system itself, and complications like aqueduct stenosis, which can block fluid flow in the brain and cause hydrocephalus. We mentioned intracranial and spinal meningiomas are common in NF2. Epilepsy occurs in a small percentage of NF1 cases. And significantly, cognitive issues, things like learning disabilities, ADHD, they're actually quite common in NF1 and really important to recognize and manage.
You also mentioned cardiovascular issues linked to NF1. That seems a bit unexpected.
It might seem so, but yes, the notes list congenital heart disease as a possibility, and also renal artery stenosis. That's a narrowing of the arteries supplying the kidneys. That stenosis can cause high blood pressure. And the pheochromocytoma, the adrenal tumor we mentioned, also happens in about 2% of NF1 cases and can cause hypertension and palpitations.
Wow. It really is a multi-system disorder then, isn't it? Especially NF1.
Absolutely. It affects so many different parts of the body. The notes even touch on potential respiratory, GI, psychological, endocrine, and obstetric complications in NF1. It just emphasizes the need for really comprehensive, regular monitoring. These varied clinical features, and especially those specific diagnostic criteria, are absolutely essential knowledge for anyone revising this topic. And notice, like you said, NF1 often gets picked up earlier, maybe in childhood, because of the visible skin signs. NF2 tends to present later, often with those hearing issues.
Given all those potential findings, how do doctors actually confirm a diagnosis or screen for complications? What investigations are typically used, based on the notes?
Okay, investigations. The notes state pretty clearly that the diagnosis is primarily clinical. It relies on recognizing those signs and symptoms we just spent time on and applying the diagnostic criteria.
So you look for the Café-au-lait spots, the Lisch nodules, neurofibromas, etc.
Exactly. Genetic testing can confirm the diagnosis by finding the specific NF1 or NF2 mutation, and it's certainly useful in ambiguous cases or for counseling. But the notes stress it's not routinely recommended as the initial diagnostic step for everyone.
So you don't necessarily need a gene test to make the diagnosis if the clinical picture fits the criteria.
Correct, based on these notes. If the clinical criteria are met, the diagnosis can often be made.
What about imaging?
Imaging studies are crucial, but more for assessing the extent and location of tumors and looking for complications rather than making the initial diagnosis usually. MRI is generally preferred, especially for imaging the head in NF1 cases.
When would you do an MRI?
You'd consider it for specific reasons, like assessing the brain ventricles if you suspect hydrocephalus, looking closely at the optic nerves, investigating persistent headaches, or evaluating potential lesions in the chest, spine, or abdomen if symptoms point that way.
Any other test?
Plain X-rays can be useful for looking at bony issues like dural ectasia, which is a widening of the spinal canal lining, or other skeletal abnormalities like scoliosis or bowing. Electrophysiology, like an EEG, if there's a suspicion of seizures, maybe myelography or visual evoked potentials, VEPs, in specific neurological situations, though less common now with MRI.
And the eye exam.
Oh yes, that slit lamp eye exam by an ophthalmologist is vital for finding Lisch nodules in NF1, especially helpful in older individuals or when checking a parent of an affected child for subtle signs. And hearing tests, of course, are absolutely critical in NF2 to monitor auditory and vestibular function over time.
The notes also had a specific point about what not to do routinely for diagnosis, didn't they?
Yes, that's a good point for revision. The notes explicitly advise against routine baseline brain and spinal MRI scans just for diagnosis if there are no specific symptoms. Same goes for routine imaging of the chest or abdomen without a clinical reason. You image when there's a specific question to answer based on symptoms or findings.
Interesting. So it's a genetic condition, but the diagnosis often starts clinically with targeted investigations.
Exactly. It highlights the importance of careful clinical examination first and foremost.
Okay, so once someone is diagnosed, how are these conditions managed? The notes seem to cover monitoring, surgery, medication.
Right. The overall principle is basically monitoring the disease progression closely and then intervening when tumors cause symptoms or if there's a concern about malignancy developing.
How does that apply to NF1 specifically?
For NF1, those common Café-au-lait spots and the typical small cutaneous neurofibromas, they usually don't need any specific treatment themselves.
But what if a lesion is causing problems? Pain, looks bad, pressing on something.
Then surgical excision is an option, though the notes do caution there's a risk of recurrence, the tumor growing back. For plexiform neurofibromas, remember those are the ones with malignant potential. The approach is often wide local excision, if possible.
Are there medications mentioned for those?
Yes, the notes mention two. Imatinib can sometimes help decrease their size, and a newer drug, selumetinib, is noted as being effective for inoperable plexiform neurofibromas, specifically in children aged 3 and older.
What about other NF1 issues? Neurological symptoms,
Aye.
eyes, learning.
Any new neurological symptoms or changes need prompt monitoring and referral to a neurologist. Optic gliomas are managed with close ophthalmological evaluation and often chemotherapy if they're progressing or threatening vision. And those learning and behavioral issues, which are common in children with NF1, also require ongoing monitoring and appropriate support services.
Okay, and NF2 management. Sounds like it would be heavily focused on those bilateral vestibular schwannomas.
It absolutely is. Management involves regular assessments, hearing tests, eye exams, MRI scans to track tumor growth, audiology evaluations, sometimes tests like brainstem evoked potentials. Symptomatic tumors, especially the vestibular schwannomas, are the main target. Treatment options include surgery, trying to preserve hearing as possible, or sometimes radiation therapy.
Is there medical treatment for NF2 tumors?
Yes, the notes mention bevacizumab. That's a VEGF inhibitor, an anti-angiogenesis drug, which is sometimes used to try and shrink or slow the growth of NF2-related tumors, particularly the vestibular schwannomas. And of course, MRI of the head and spine is necessary when NF2 is suspected, and interventions focus on preserving hearing and preventing brainstem compression.
What about managing schwannomatosis? Pain was the big issue there.
Exactly. Pain is the primary target. Management involves medication for pain control and surgery to remove specific painful schwannomas. The notes highlight that specialist care is often needed for complex tumor resections. And while surgery can improve pain from a specific tumor, it becomes less effective overall if someone has many, many tumors. You have to consider the cumulative impact of multiple surgeries on pain.
Makes sense. What about long-term follow-up for adults? How often do they need to be seen?
The notes suggest, for older adults with NF1, perhaps annual clinic visits. But severe or complex cases, across all types really, require lifelong specialist monitoring. Even people with milder cases should probably have annual blood pressure checks with their GP and consult them for any new or unusual symptoms that arise.
And managing those secondary issues you mentioned earlier, hypertension, skeletal problems, etc.
Yeah, medications are used as needed for conditions like hypertension, epilepsy, or ADHD if they occur. Surgery plays a vital role for certain complications. Spinal cord tumors causing neurological symptoms need prompt intervention resection, might prevent paralysis or offer palliation. Rapidly progressive or severe scoliosis and other significant bony defects need urgent attention, early orthopedic referral, and might require bracing, casting, or surgery. Renal artery stenosis causing that high blood pressure, that can sometimes be treated with procedures like angioplasty, PTRAA, or surgical repair. The real key takeaway for management, I think, across all types is that it's highly individualized. It needs a multidisciplinary team, neurologists, surgeons, ophthalmologists, audiologists, geneticists, pain specialists, and it's really centered on managing the symptoms and complications as they arise, monitoring closely rather than, curing the underlying genetic cause itself.
Right, managing the manifestations. So looking at the longer term then, what's the outlook? What's the prognosis for people with NF? The notes seem to differentiate between NF1 and NF2.
They do. For NF1, because of that huge variable expressivity we talked about, the prognosis is quite varied. It's hard to predict for an individual. Many individuals with NF1 can lead relatively long and healthy lives. However, the notes do state that overall life expectancy may be reduced compared to the general population, likely due to the potential for complications like malignancy or cardiovascular issues.
And NF2 generally has a tougher outlook.
Yes, generally NF2 is associated with a worse prognosis. The complications, particularly from the growth and treatment of those bilateral tumors, can be more severe. Morbidity, illness, and disability related to the condition and its treatment is a significant concern. However, the notes are also clear that early detection and prompt, proactive management of these complications can definitely improve outcomes and reduce both morbidity and mortality in NF2.
So vigilance is key for both, but maybe especially critical for NF2.
I think that's fair to say. While NF1 is generally less severe overall, both conditions absolutely require lifelong vigilance due to that potential for serious complications down the line.
Can NF actually be prevented? The notes touched on genetic counseling.
Well, you can't prevent the initial spontaneous mutation, obviously, but for families where NF1 or NF2 is already known, you can address the transmission risk. There is that 50% chance of passing the mutation to a child because it's autosomal dominant. And the notes explicitly state, importantly, that you cannot accurately predict the severity of the condition in a child who inherits the gene. One parent might be mild, the child severe, or vice versa.
Is examining the parents important if a child is the first one diagnosed with no known family history?
Absolutely, the notes recommend this. Parents of a newly diagnosed child should be examined carefully for subtle signs, especially with NF1's variable expressivity. They might have very mild features they weren't even aware of.
And if the parents are checked and seem completely unaffected?
If the parents are clinically unaffected after a thorough exam, the risk of them having another affected child is actually extremely small. The notes quote it as less than 1%. This suggests the first child's case was likely due to a new mutation in the egg or sperm.
And there are options for families who know they carry the gene and are planning a family.
Yes, the notes list several options available now. Genetic testing can identify the specific mutation. Genetic counseling helps families understand the risks and their choices. Prenatal testing during pregnancy can detect the mutation in a fetus. And pre-implantation genetic diagnosis, or PGD, is an option with IVF testing embryos for the mutation before implantation.
So there are choices, but still that uncertainty about severity if the gene is passed on.
Exactly. It raises complex issues for family planning, and counseling is key.
Okay, finally, let's talk about complications. What are the potential serious problems people with NFF might face over time? The notes list several key ones.
Right, complications. A major one is an increased risk of certain cancers. Brain tumors are generally more common, particularly in NF2 with meningiomas and schwannomas. Individuals with NF also seem to have a slightly higher risk of leukemia. But a really key complication highlighted is the risk of malignant transformation of neurofibromas.
Especially the plexiform ones in NF1, right, becoming MPNSTs.
Exactly. Malignant peripheral nerve sheath tumors, or MPNSTs. These are aggressive sarcomas that arise from nerve sheath cells, strongly associated with NF1. The notes emphasize they lead to poor survival rates. That's a major concern.
So the benign tumors turning cancerous is a big risk.
It's a significant concern, yes, particularly that MPNST risk in NF1. Other complications really stem from the effects of tumor growth itself. Neurofibromas getting larger and compressing nearby structures, like nerves or the spinal cord or organs.
What about specific complications we touched on earlier?
Yes, the notes reiterate things like potential vision loss from optic pathway gliomas in NF1, the skeletal abnormalities, scoliosis, pseudoarthrosis, bowing, the learning disabilities common in NF1. And they also mention the social and psychological challenges that can arise, especially if someone has very visible skin manifestations. It can impact self-esteem and quality of life.
So increased tumor risk, especially MPNSTs, compression effects, skeletal issues, learning issues, psychosocial impact.
Exactly. These potential complications really underscore why NF is considered a systemic condition and why that multidisciplinary, lifelong monitoring and proactive management we discussed is just so critical. So, what does this all mean when you're trying to revise this? We've gone through the genetics, the incredibly varied symptoms, the sometimes tricky diagnostic puzzle, and the need for lifelong management. Thinking about that 50% spontaneous mutation rate, and especially the extreme variable expressivity in NF1, how does knowing that complexity change how you might approach, say, a clinical scenario or an exam question about NFS? It's not just about recalling isolated facts, is it? It's about understanding that potential breadth of presentation, that unpredictability sometimes.
Wow, yeah, we really covered a lot there. A proper deep dive into neurofibromatosis, hitting everything from the foundational genetics and those really diverse presentations, right through to the diagnostic criteria, the investigations, management strategies, all pulled from your revision notes.
Hopefully, yeah, breaking down the material like this helps clarify those really key distinctions, especially between NF1 and NF2, and maybe makes those detailed diagnostic criteria, those lists of 7 for NF1, the rules for NF2, a bit more memorable for your revision. Definitely focus on those differences, and the diagnostic rules, they are absolutely high-yield areas.
Absolutely. This deep dive was designed specifically for you, the learner, to help you cut through the complexity of NF1 and really focus on the most important takeaways for your studies. Keep revisiting these points, keep connecting them back to potential clinical scenarios. And if you're currently preparing for the MSRA or maybe other medical exams, remember to check out passthemsra.com. They've got loads of high-quality revision resources.
That's right. And for a great collection of free MSRA revision materials, you can head over to freemsra.com. Well worth a look.
Thanks so much for joining us for this deep dive. We really hope it's been incredibly helpful for your NF revision.